right, so we have a good number of us, so we're a minute after, so we can get started. Thank you guys so much for coming down. I'm Nilika Singhal. Nice to meet all of you. I'm not a surgeon. I'm an epileptologist at UCSF, just up the road. We're going to talk today about a surgical evaluation, and although the title says pediatric surgical evaluation, I think that the content that we'll cover applies across the ages. And so this is sort of what folks are thinking about before you actually meet the surgeon and before you approach the operating room. So hopefully what we talk about is relevant to everybody regardless of your age. I don't have any disclosures relevant for Epilepsy Awareness Day. I wanted to start with just introducing myself. I see some friendly faces, familiar faces in the audience, but for those of you who I'm just meeting, I'm a pediatric epileptologist at UCSF Benioff Children's Hospital. I spend a lot of my time looking at EEGs, working with residents, fellows, medical students, talking with kids and their families about epilepsy and our treatment options for kids living with epilepsy. As I mentioned, I teach also. I work with trainees across all the levels, and it's one of my great joys in getting to work at an academic medical center. And then in addition to that, I'm also a mom. So we've got 3 kids. Our youngest on the right here is hanging out at the park today with my partner, and the big 2 are home with grandma and grandpa because they have school. So that's a little bit about me. I would love for this to also be informal, so we'll have time for a formal Q&A at the end, but as things come up, if I'm not clear, please don't hesitate to shout your questions out and we can pause and take a moment. So our objectives today, we're going to talk about understanding a pre-surgical evaluation. I hope this piggybacks nicely off of Monica's beautiful talk just before me, but I'm hoping by the end of our time together, you'll really understand who epilepsy surgery is for. I want you to be empowered with the knowledge to distinguish between all the phase 1 components, what phase 1 even means, and then what goes into all the different elements before making a decision about something like epilepsy surgery, and then to think about our treatment options and apply them as broadly as we can to folks living with epilepsy. So why am I talking about this? As I mentioned, I'm not a surgeon, but epilepsy surgical decision-making starts really early in my mind. As Monica mentioned, I really do not view surgery as a last resort ever, under any circumstance. And in fact, for many people, undergoing epilepsy surgery could be the first day of the rest of your life. And so I think about this, as kids meet me in clinic for the first time, even if we're not talking about that day, I'm thinking through, okay, plan A, plan B, plan C, plan Y for this kid and for their family. And so this decision-making starts early, and I'm hoping that you all are really empowered with the knowledge and the types of questions you can be asking as you're taking care of your loved one. And this is very confusing, and it's very scary. Our kind of decision-making algorithms are super wordy and super confusing with a lot of jargon, so I'm hoping that all of that is demystified by the end of our session today. So as Monica mentioned prior to our time together, epilepsy surgery is for people with what's considered medication-resistant, historically focal epilepsy. I would venture to say that this notion is changing, and so this type of treatment option should apply broadly, regardless of whether your epilepsy is classified as focal versus generalized, which we'll get into also. And that really is defined as a failure to achieve seizure freedom despite good trials of at least 2 anti-seizure meds. So it's not when you're at your 10th med or your 15th med or your 20th med. We really need to be thinking about other ways to take care of people living with epilepsy beyond medications when we've tried 2 and that they haven't worked. And this is based on science. Up to the chance of becoming seizure-free with your 3rd, 4th, 5th, 8th medication just drops down lower and lower. And so that really it behooves us to think about all treatment options early on. People who are unable to achieve seizure freedom, despite 2 trials, it's like 30 to 40% of all the people living with epilepsy. So it's a good chunk of us. It should not be a rare, last resort type of situation. And then why does this matter? Through many studies, as Monica also touched on, the degree to which we can achieve seizure reduction, seizure freedom really influences our quality of life. For children, this can really help with our overall developmental trajectory and ability to do the things that typical kids want to be doing with their life. This will reduce our overall mortality, risk of death, risk of other disability. The quicker and the earlier we can reduce the burden of seizures. The brain also is such an interesting organ. Obviously, we're all here because we're interested in the brain, but the brain learns patterns. And so the quicker we can reteach the brain to avoid a seizure pattern, the better it can learn that. So it's sort of, in our field, we view this as something to not wait on. It's something to think about early on if we can offer a treatment that could really change the course of the way that somebody's brain can learn those patterns or unlearn the seizure patterns, for example. Okay. So your loved one have tried 2 anti-seizure medications. They're not working. Now what? I really think that getting seen and treated at a comprehensive epilepsy center is that first step to understanding, now what do we do? Again, we shouldn't wait till our 8th medication that we're trying, but really get in to see an epilepsy specialist or team at a comprehensive epilepsy center. And as Monica touched on, there are so many different types of surgical options that it can be extremely confusing. And what goes through our minds are what treatment can really help this person achieve a better quality of their life, make it worth it to them by reducing their seizure burden, but also improving other aspects of their cognition or their mood or their connectedness with their loved ones. A big leap that it takes to get somebody to the operating room. So the surgical options are just really vast. They include open craniotomy, which means like removing the actual cranium, which is our skull, to do a resection, like removing brain tissue, or a disconnection, like cutting the way that one part of the brain communicates with another part. There are less invasive surgical approaches, including laser treatments, radiosurgery using specialized tools. And then nowadays we have neuromodulation, which is another tool at our disposal to not remove any brain tissue, but to modulate the way that brain tissue is functioning to reduce seizures in the long run. And so we'll talk about VNS, which is vagal nerve stimulator, responsive neurostimulation, and deep brain stimulation towards the end as well. So I'd love to spend some time distinguishing the components of when we're talking about phase 1, what that jargon word means, and all the different pieces that go into evaluating an individual before offering them surgery or before talking about what surgical choices are best suited for them. So this decision tree is very confusing. You can see at the very top, box A talks about somebody who's having seizures after more than 2, and this is a little bit of an older terminology, anti-epileptic drug. We're saying we have modified our language to anti-seizure medication at this point, and that's when that initial branch point occurs. And the second branch point here, when we're talking about epilepsy subtype, can be confusing, and it can lead to some, lack of understanding or lack of communication from our part to folks that we're seeing in clinic. So I wanted to touch on that for a little bit. What does focal versus generalized mean, and how does that play into all of this since it's near at the top? So these are some old pictures of slices of brain, kind of top to bottom. So it's like these kind of crown-like coronal sections. And this is supposed to be a diagram of what a focal seizure may demonstrate. So there's an initial electrical abnormality happening in just one part of the brain. So focal is synonymous with partial. Those terms are totally interchangeable. The other term that's also interchangeable is localization related. So all that means there's one specific area that we think is the first domino in that cascade of dominoes that's producing a seizure. And so after that first domino falls, it can spread to other parts of the brain, but that basically defines a focal seizure. Sometimes that's really clear based on someone's symptoms, based on what you're experiencing during a seizure. Sometimes that suspicion is confirmed on a test like an EEG that we'll talk about in a few slides. So that's what we mean when we say focal. And then focal seizures can spread and then can become secondarily generalized, and so they're not starting all over the brain altogether, but they're starting in one corner and then spreading and involving other areas too. Monica touched on this in the hour before us, but we can see here that this focal seizure is starting, and then really quickly it's spreading to these deeper structures like the thalamus and other deeper brain structures. Those are really these like relay networks, and so can propagate seizures to spread to all over the brain to become secondarily generalized. So that's what that refers to. And then another type of like classification that we sometimes think about are just generalized seizures right from the get-go. And so when we're looking at a seizure on the EEG, it looks like all the electrodes are involved all at the same time. Those seizures also really frequently involve these deeper relay loops within the thalamus and other deeper structures, but we're seeing them on the EEG altogether. So when we're hearing these terms about focal versus generalized, hopefully that helps us to understand a little bit more of what that means. And with these focal seizures, sometimes it feels like we're searching for the needle in the haystack. Like, where is that exact spot where the seizure is coming from? Can you see it on an MRI? Can we see it in any other way? Does that give our surgeon a target to kind of go after? Versus generalized, does that mean that the entire brain is involved? And if so, what does that mean for surgical treatment options? And so we'll talk about that in our time together. All right, so when we're seeing folks in clinic and thinking about our phase 1 evaluation, that's basically our first touch point in trying to understand someone's epilepsy and what is considered a non-invasive way. I would say that's like, that term, it doesn't really speak to the amount of effort and the amount of time lost away from your families, time off of work to like do all these things in our epilepsy monitoring unit, coming into the hospital for a video EEG, having all these things attached to you. That's all part, like included in this phase 1 evaluation. And so basically it's all the things that we do before somebody opens up your skull or before somebody actually is entering the operating room. So everything prior to that is kind of lumped into our phase 1 evaluation. That includes the very basics, the first time that you meet with your epilepsy doctor in clinic and they're asking about your medical history and understanding the symptoms that you're feeling or that you're observing in your loved one, to try to do their neurological exam to look for any differences in the way that your brain is contributing to the neurological movements and the neurological exam components, and then what type of seizures that your loved one is having. We use EEG monitoring to define the epileptogenic zone. So like going back to the other slide, that's that first spot where the seizures are coming from. Sometimes the EEG can pinpoint that if it's like showing where the seizure is starting. As Monica had mentioned too, though, all these tests have their limitations, including EEG. And so a scalp EEG really should be interpreted in light of somebody's symptoms, what it seems like their symptoms are pointing to, which part of the brain, and does that EEG confirm that suspicion or not. It's not a perfect test, and so there are limitations to it, and hopefully your doctor is explaining that in a way that makes sense for you. We'll talk through these different types of imaging modalities, including MRI, PET, SPECT, MEG. I'll touch on neuropsychological testing, and then talk about a multidisciplinary approach. After all that's done, then that's when this like conversation with our surgeons may happen and talking through phase 2, which is basically more invasive and involves going to the operating room to understand more about where the seizures could be coming from in the brain. So there's a whole bunch that happens before you meet your surgeon. Okay, so our overall, to kind of think about who's a great candidate for what type of surgery, it really starts the moment that you set foot in your epilepsy clinic with your epileptologist to talk about your history. And so thank you for bearing with us when we ask these questions. It's super helpful to understand how long you or your loved one has been experiencing seizures, really what they look like, what the first symptom is that you experience or that you observe. It really helps us to pinpoint what that first domino is in the pattern of how seizures begin and how they spread. Sometimes folks take a home video, which is useful for us to be another set of eyes in the room. If your loved one is able to take a video when you're experiencing a seizure, that can be helpful. And your symptoms that you experience can really be such helpful clues to pinpoint which parts of the brain produce that type of symptom. And so sometimes the EEG might be unrevealing, or MRI also have limitations, but your symptoms, like what you're experiencing, can really pinpoint where in the brain that seizure is expected to be coming from. So it can be super highly accurate in lateralizing which hemisphere and which lobe of the brain. There are some caveats. Sometimes folks have multiple types of seizures, and so symptoms can be coming from different parts of the brain, of course, or a seizure might have a beginning someplace and then spread someplace else, and then that's when the person experiences a symptom. And so there's caveats in terms of trying to correlate the symptoms with where in the brain the seizure is coming from. We'll also ask about any associated symptoms, like does the person have other reason to see a neurologist or a neuropsychologist? Are there coexisting mood differences or attentional differences or executive functioning differences? And those things can help us with understanding how the epilepsy overall is affecting someone's quality of life. We do a thorough physical exam, so we look for other differences in the way the brain is manifesting. So if there's other changes in neurological functioning that we can pick up on someone's physical exam, that can help us with surgical planning. And then we'll go through in probably excruciating detail all the seizure subtypes and hopefully take detailed notes so we remember all this important information that you're sharing with us about the different types of seizures your loved one may be having. Yeah. Yeah. Oh, great question. So yeah, so what I'm trying, let me see if I'm understanding this, is are these things that you have to sort of pass in order to progress to the next stage of surgical monitoring? That's a great question. I view these tests in terms of trying to really understand each individual's brain functioning, whatever their baseline is. So there isn't, like, for any of the tests listed here, there is not a point that we'd say, oh, you know what, you're because of this test alone, surgery is not an option for you. It's not, I don't view it like that. I think that each of these offers information, and then we come back to folks that we see and have that conversation about is it worth it? So, for example, what if somebody comes to see us and they're having seizures that are disabling and that they're interfering with your quality of life, but our EEG was inconclusive, it just didn't, the EEG is not a perfect study, and what if it didn't pick up the seizure onset? And your MRI is totally normal, which happens to many people living with epilepsy, and we're unsuccessful with our attempt at a SPECT scan or unsuccessful with our attempt at a MEG, that does not mean that you're disqualified or something like that, but it sort of may help us to inform, is it worth it? Should we go through invasive, using electrodes implanted in the brain and undergoing that kind of diagnostic uncertainty? Undergoing that doesn't guarantee that you would then go on to have a resective surgery. It may just be more information. And so for each person, that's not a blanket answer. For each individual, that's a super individualized question, and I hope that your team is helping you to understand, these are the risks for you, this is what we expect out of the next step, but here is what we could do as the next step. And then the neuropsych testing we'll talk about towards the end, and that also is, the brain obviously is not just responsible for seizures and nothing else, and so it's trying to help us pinpoint if we have a suspicion where seizures are coming from. The point of neuropsych testing is to either lend more corroborative data to that, to say, you know what, that part of the brain we suspect produces seizures, and also it's supposed to do XYZ function, but we can see from this testing that it's not doing the XYZ function. Maybe that, lends strength to that hypothesis that we've pinpointed where the seizures come from. So it's not a pass-fail type thing. It maybe just adds more texture to the big picture about, do we think we have an idea where the seizures are coming from? If so, how do we treat seizures from that part of the brain? And can these information help that or not? Even when all of this is inconclusive or uncertain, many people embark an epilepsy surgery step sort of trying to understand, is that uncertainty still worth it for that individual? And so I don't think at any point would be you're disqualified. It kind of just depends on the person and their seizures and what's expected out of which surgical option we're talking about, and is it worth it to that individual? Fantastic question, thank you. All right, so many folks in the room have probably experienced some type of EEG monitoring. So this is just a picture of our children's hospital in San Francisco. This is part of our phase 1, otherwise known as a scalp EEG. So kids get admitted to the hospital in this room, and we'll attach electrodes to the surface, to the scalp of their brain, and they've got all these wires connected to a backpack. The cord is supposedly long enough that you can get up and walk around the room, and there's a private bathroom where you can go and do your business. But it's really, you're kind of tethered in that environment to record your brain activity. So it's like longish term. I would say that sometimes people are admitted to our epilepsy monitoring unit for as short as a day or two, as long as a week or two. And it depends on the person, and especially with a kid, their ability to tolerate being sort of tethered to these machines to look at their electrical activity. There's also a video camera that's hardwired in the ceiling, and at our center we have technicians looking at the EEG squiggly lines 24/7 and keeping an eye on the camera so that even if their caregiver or their loved one is asleep and worried about missing something, we've got another set of eyes on them to hopefully keep them safe. Sometimes when folks come in, even this scalp EEG monitoring, it's not a one size fit all, and it depends on the person's seizures and likelihood of catching a seizure in this amount of time. So if somebody is having seizures every day in their daily life, then the yield of bringing them in to record them is really high, because we'll have a great chance of capturing them. If somebody's having seizures a couple days out of the week, the yield is also pretty good, and maybe we'll have them come in and even reduce some of their anti-seizure meds when they're being monitored safe in the hospital to try to almost provoke some of their typical seizures. We always want to be gentle with that, though, obviously, and not inadvertently provoke something that's unusual for them or more intense for them. So that discussion is done really carefully, and making sure that everybody has a good understanding of our contingency planning of what happens if XYZ would occur. But the yield isn't perfect, and for whatever reason, this happens all the time, that folks get admitted to our hospital and they're producing seizures frequently at home, but then in the hospital it's a different environment, or people's epilepsy goes through cycles, and so for whatever reason that week their brain doesn't produce seizures. Even if we're reducing anti-seizure meds, or even if we're keeping people up past their bedtime to try to reduce the threshold that it takes towards producing a seizure. So kind of bearing in mind that sometimes those studies are not successful, and it doesn't mean that you're not a surgical candidate. Maybe it means that we try again at another road, or try about it a different option, or look at it from a different angle, such as there are ways to do these ambulatory EEGs where folks come to get EEG electrodes placed and then go back home and wear electrodes at home for a day or two, because sometimes being in the hospital environment, it just changes the stress level or something like that. And it's always funny, when you think about getting admitted to the hospital, that alone feels like a really scary thing. But for some reason, a lot of our kids, maybe it's they get one-on-one time with their parent, there's a huge TV in the room, they have this private room, and it winds up being not stressful. And so for whatever reason, the brain doesn't produce seizures. And so when that happens, we can try again, or we then talk about if there's other ways to understand where the seizures could be originating from. Questions about that so far? Yeah. That's a great question. So ambulatory, the advantages can be to keep folks in their natural environment, and maybe that will produce seizures. The disadvantage is that there isn't that hardwired video camera in the ceiling or technician monitoring it 24/7. So, being in the hospital, for example, if somebody is having a seizure, our technicians can check on them and can perform a little bit of a neurological assessment to help us understand, is this a movement difference, or is it a sensation difference, or is it the person doesn't understand, which aspect, what's producing that symptom of their arm isn't moving? Is it a motor thing versus is it a thinking thing? So we miss that level of assessment when someone has an ambulatory. And then your other question about what if I miss it as a caregiver? I don't think it should be, it's not expected to have a video camera off on your kid 24 hours a day when they're at home moving around and living in their daily life. And so that is a limitation of ambulatory. And so it depends on the kid, and it depends on the situation where, how much do we need a video to help us with understanding that person's seizure burden in that moment. Sometimes an ambulatory sometimes all we need is the EEG information, and we already made that decision beforehand. Like, what we want out of this EEG is purely the electrical activity. If that's the case, then an ambulatory could be fantastic because we don't even need the video. But if there's some uncertainty about what happens during a seizure, what the symptoms really represent, or distinguishing, is this muscle jerk like a totally unrelated to epilepsy, random muscle jerk, or is it a seizure, then maybe there's an advantage to coming into the monitoring unit to help us get that level of detail. So it depends on the situation. With our EEG, you guys have probably seen these squiggly lines. All of these squiggly lines represent electrical potentials from the brain that are picked up at different points. And in this example, blue represents one side of the brain and red is the other. And this is what a focal seizure may look like on an EEG, where there's like some change here from one half to the other. And on the red side here, the seizure is showing up as like faster frequency. Each vertical line represents 1 second of time. And so the frequencies are faster, meaning more of those squiggly lines per second compared to the blue side. And they look different. They're a little bit more organized, and they're kind of spreading in a different way compared to a generalized seizure where all of the scalp EEG may show changes at the same time. Monica touched on this, and we'll talk about it later on too, but this is like a typical montage that when you think about EEG, most centers would offer this, but even scalp EEG can differ from center to center, and so I'll explain what that means in the next couple slides too. So when someone has a focal or a partial onset, that first domino of the seizure, if it seems to be from one specific spot, that epilepsy may be amenable to a focal resection. Removing the hot spot can in terms of our literature, can often afford folks the best chance at curing them from their epilepsy. And so we're always curious about that. But these are the things that I think about. Are the seizures focal or partial in the first place? Are they coming from one spot as opposed to multiple different areas? Can we find that location, either on imaging or even using other specialized electrodes that can be implanted in the brain? And then, is that resection possible without unacceptable neurological deficits for that person? So is that part of the brain in an area that can be safely treated with surgery? And we hope that our imaging, the other components of our non-invasive testing, can help us to answer that question. So we'll talk about that too. And then this is just a scalp EEG picture of what a generalized onset seizure may look like. So when you look from like top to bottom, all these squiggly lines are producing what more spiky looking waveforms, and there's not one region or one side that's having more change than the other. So again, the scalp EEG is just to add some texture to it of what a generalized onset seizure may look like. Now, after our EEG testing is done, the next step for a lot of folks is imaging. And when we're talking about imaging, you can think of it in two different buckets. There's structural imaging, and then there's functional imaging. So structural is just straight up looking at the structure of our brain. That, for many people, starts with an MRI, magnetic resonance imaging, and that's looking at the structure, the folds, the spaces. Is it the same from one side to the other? Is there a part that the structure looks different compared to other folks of that age group? There are other types of imaging that we'll touch on briefly, including DTI, CT, angiography, MRI, or MRA are also other types of structural imaging, but by and large not as relevant for folks living with epilepsy. And then functional imaging isn't looking at the structure of the brain, but it's more how the brain is working. And so PET scans, SPECT, fMRI, and MEG are all different types of what's called functional imaging. Sometimes when you're going through the first steps of thinking about surgery, an MRI is like all that we need. And so for some people, when we have confirmed our type of seizures, we've done our detailed neurological exam, we've done our scalp EEG, things are matching up and sort of fitting what we have as a hypothesis for where that person's seizure is coming from. And the MRI matches up. For some people, that's like the end of the pre-surgical evaluation, and that's all that we need, which is perfectly fine. But to your point, if the MRI doesn't show anything, does that mean that person isn't offered surgery? Maybe not. I think that means that we need other types of tests on their epilepsy, and that's where our functional imaging comes in. So starting with structural, this is brain MRI. This type of test is what's called interictal, Inter meaning in between, and then ictal meaning seizure. And so this is just done at someone's baseline. It has nothing to do with them producing a seizure. It's an interictal study, so that means you can get it as an outpatient. You don't have to like time it to when you're having a seizure, and it's only looking at the structure of your brain. But MRI is not created equal, and so we really want a high quality. You can remember, like, the first iPhone 15 years ago took digital pictures, but they're super different now. And so similarly, technology has advanced. It keeps advancing. I think we're up to 11T for some research studies. But what we consider as our gold standard for people living with epilepsy is this like 3T, 3 Tesla, refers to the magnet strength and magnet quality structural brain MRI. And if we can find the needle in the haystack for our surgeon, then the chance of curing someone with a resection really is improved a great deal. And so, for example, this is just an example image of what's called a coronal view. So it's like a slice of brain from top to bottom, like someone's wearing a crown. And the little orange circle here, it may project subtly, but we can see on this side, the normal side, the delineation from the gray part here to the white part is really crisp. But in this area, it's like smudgier, and it looks a little bit different than the other side where it's really crisp. Not only is that distinction smudgier, but the gray matter is a little bit thicker than it should be. So those are the types of comparisons that we're making. And we rely really heavily on having a skilled neuroradiologist to help us look at that. I'm lucky to work at UCSF, where the neuroradiology team are excellent and have been instrumental in helping us find the needle in the haystack for a lot of folks. And then on this one, this is also a coronal view, so it's like you're looking at the person and the image is kind of top to bottom. These structures in the middle here are the hippocampi, which for a lot of adults are a common area that can be involved in seizure, adults and children, seizure generation and seizure propagation. And so sometimes we're looking for smudging and blurring, like in this one. And sometimes we're looking for a change in the brightness or the change in the size. So this one here looks a little bit smaller than the one on the other side. And then inside the hippocampus structure, there's some brightness that we see here that we don't see on the other side. So these differences can be really subtle. Even though it's my profession, I still really love to have an opinion from a skilled neuroradiologist to help us with that decision-making process. And so when we see folks for a second opinion or a third opinion, we definitely have our neuroradiologist review the scans that they may have already obtained to help us know, is this really up to snuff, or do we need to repeat that at our center to make sure it's like of tip-top quality? But we start with reviewing the data that's already collected for sure to just give that the benefit of the doubt. Okay, so then moving on to structural images, the first that we'll touch on is called PET. It stands for positron emission tomography, which is a total mouthful, but we call it PET for short. And basically, this is not looking at the structure. You can see this image is like super grainy and not that well detailed, but we're looking at the way the brain metabolizes, like the way it processes energy. And so how it works is that we can, so in general, the premise behind it is that if there's a part of the brain that's producing seizures often, even when it's not producing seizures, at baseline, the metabolic activity in that region will be different compared to the rest of the brain. And so this is also interictal. It's not depending on timing it to when someone produces a seizure. And we know that at baseline, an area of the brain that's a hotspot that's frequently producing seizures will have a difference in its level of metabolic activity in general. And so somebody would get this labeled glucose injected in an IV, and then it's picked up differently in a part of the brain that's producing seizures. And so there are a few studies, too, that show, especially in adults with temporal lobe epilepsy, that having a PET scan that shows which temporal lobe or which hippocampus is responsible is like as good as an MRI. And so there are some types of epilepsy where when the MRI is normal and we have a PET scan that helps us, the surgical outcome can be just as robust. And so like having a normal MRI, again, doesn't like preclude the rest of it. It's just we need to think about other ways to understand that brain. And at UCSF, we often combine PET scan with the CT scan or with an MRI. So we're lucky to have that option through our radiology colleagues where we can like overlay the two of them to increase the diagnostic yield of just one of those and take it in isolation. So basically, the sum is greater than each of its component parts. And so if we have an MRI or a CAT scan, and then we overlay it with a PET scan, then we can get this really super detailed. So this is just like the PET alone, and then this is superimposed on the MRI to really delineate like which part of the brain is producing seizures. So some centers offer that, not every center does. And this is just kind of playing that statistics game. So again, even when our PET scan is normal and our MRI is normal, that person may still be a really great surgical candidate, but what we're trying to do is make it as easy as possible for our surgeons by like showing them this is the hot spot, this is where we need to go, and then we can understand how safe or is it worth it for that person. So PET scans, how that works in real life is that it's outpatient. Sometimes kids are able to do this without anesthesia, but anesthesia is an option study. And so we can schedule these as an outpatient. You don't have to get admitted. You don't have to be in the epilepsy monitoring unit. You don't have to like wait for seizures to come on because it's interictal. Okay, and then, yeah. Yes. Oh, great question. So this glucose, they're both different. I think of them as both different types of like tracers that can get injected in an IV. Both of these are radio labeled, and so they'll be broken down. They don't linger in the body forever. And so there's a tracer that we'll talk about that's a different one than labeled glucose like you're talking about, but it's like in that same kind of vein in that they're both products that will decay in the body that can, for a short amount of time, be active and show us some differences in the brain. So it's timed. So like somebody would have this glucose injected, and then the window of time to get the PET scan is a couple hours after that before it will decay. You can come hang out with me. Yeah, that's a great question too. So for PET is like at our center specifically uses glucose because it's looking at metabolic activity. There's another dye that we'll talk about in a couple slides that's not looking at metabolic activity. That's where the glucose is helpful because glucose is a sugar. It's sugar, and it's how the brain. That's like the source of energy for the brain, and so that's the type of. That's what we need to inject to do a PET scan in the first place because it's looking at specifically how the brain like uses sugar to do its normal processes. But there are other tracers that look at, instead of looking at metabolism, they're looking at like the rate of blood flow, for example. And so that doesn't need a sugar or like, a sugar molecule. It's just looking at how much blood is being taken up. So we'll talk about that in a couple slides. Great questions. Okay, so this is another type of imaging that you may have heard of called MEG. It stands for magnetoencephalography. And this type of, have anybody heard of this before, MEG? Yeah, thank you. So this one, you may recall, like it also involves a bunch of electrodes attached to your scalp. And so it looks like you're gonna have a test like an EEG done, but instead of looking at electrical activity, we're actually looking at magnetic potentials. And so it's recording brain activity. We get this output of some squiggly lines that look like an EEG for all the world, but it's looking at magnetic dipoles. And this is also an interictal study, so it's not dependent on your loved one producing a seizure in that moment. It's looking at kind of interictal activity. And the reason is that many of you guys have heard of like interictal spiking before. So the EEG or MEG scan, it's looking at surges of activity that are happening in between seizures. And so sometimes your neurologist would talk about EEG showing spikes or showing discharges. Those are called like discharges or spiking of electrical activity that happen all the time in between seizures. They can support, they can lend supporting evidence. So it can be other clues about where the hot spot in the brain may be. Some people will have seizures on an EEG, and in between them, nothing at all. So some people, for whatever reason, your brain is not producing spikes in between seizures. It doesn't mean you don't have epilepsy. It means that for whatever reason, your brain in between seizures doesn't show other interictal spiking. That can also happen on a MEG. And so this is a limitation of this type of study. It doesn't fit for everybody's individual circumstance. But we may know, for example, if you come to the epilepsy monitoring unit and you're admitted for 2 or 3 days and we record 3 or 4 examples of your seizures, and in between your seizures, your brain also produces a lot of other electrical surges of activity, maybe you'd be a good candidate for a MEG, because we know that your brain produces spiking activity regularly in between your seizures, and so that type of situation may be a good one to check with a MEG scan. So again, it's interictal. It's measuring these magnetic forces generated by brain activity. And one other piece here is that at UCSF too, these squiggly lines, these magnetic sources, can also be mapped onto someone's own brain MRI to get this like combo product called magnetic source imaging, or MSI, which can be super powerful too, because then you're looking at it in 2 dimensions instead of that flat MEG scan with just the squiggly lines. Now we're saying, okay, let's put that data on top of someone's MRI and to know, is it from the surface here, or is it deeper down, and which lobe and which area of the brain? So using that combination technique can be super helpful for people that, if it's like the right context, like for people who are able to, their brain is producing spikes in between their seizures and they're able to lay still for that type of a scanner. It's an outpatient thing. I think there are very few MEG scanners around. I think it's a rare type of thing. And at UCSF, it actually is housed in the adult hospitals. It's not within our children's hospital. So that becomes relevant, is like the ability to lay still, because we can't offer pediatric anesthesia for kids. So that can be limiting. So if we sort of have to work on that, like, are we able to have their families coach them through laying still, and our technicians can talk them through it or not? It depends on the situation. So it's another limitation of MEG. Yeah.
Actually waiting to come up to me soon. That's done with my daughter tomorrow, right? Is it similar to an MRI then, where they normally would be sedated, but you're saying that sedation wouldn't happen?
Yeah, exactly. So at UCSF, our MRI scanners are within the children's hospital, so we can have the benefit of pediatric anesthesia. But when we're doing MEGs, they're housed in a different facility. There are some workarounds, like can we time it for a kid's natural nap time? Can we have them stay up late the night before and wake up a little earlier so that they're maybe more drowsy during it? Sometimes your neurologist may talk with you about using something like melatonin or like a clonidine, which can help kids feel drowsy without changing their electrical or magnetic activity at all. So there are like workarounds to help like promote drowsiness. But depending on the timing, your doctor can talk to you about those choices, about what to do, how to manage that.
Is a MAG like a hour scan, something like that? It's not anything that would be inpatient? Like she wouldn't be admitted?
If she's coming up for a MEG, and we can talk more after about specifics, but it's usually an outpatient thing. Sometimes if I'm seeing somebody for a second opinion, we might try it, and we want other tests too, we might coordinate them. So it depends on what else is happening for your child. But it's a fully outpatient thing. Yeah, great questions. Okay, and then the other functional image that I really wanted to spend some time, there's 2 more that I wanted to spend some time on. One is called SPECT. You may notice this is the first ictal one that we're talking about. So it stands for Single Photon Emission Computed Tomography. It's another mouthful. We call it SPECT for short. This is basically, at our center, one of the main ictal studies that we have. So this is contingent on somebody producing a seizure that moment, and us trying to understand using these imaging techniques of where the seizure is coming from. So how it works, and this is, I think, the tracer that you were talking about earlier. How it works is that somebody would get admitted to our hospital, to the epilepsy monitoring unit. We're planning on having them stay with us for a few days, and then we'll plan for this day that we'll do this ictal SPECT injection. So the person has an IV already ready to go in advance, and then what the idea is that you inject a small amount of this radio-labeled tracer, and the moment that someone starts having a seizure, it's a super high-energy process to produce a seizure, and that part of the brain will typically demand a lot more blood flow and oxygen because it's such an active, hyper-excitable moment is that seizure generation. And so when we use a radio-labeled tracer injected in the vein at the time of the start of the seizure, it gets picked up by the part of the brain producing seizures a lot more readily. And so it's really contingent on all these things, all the stars aligning, like the IV being ready to go and not being jammed, the technician being at the bedside, ready with the tracer in hand, getting the timing so that usually that tracer will decay. And so we have this window of time in which somebody should produce a seizure. And so it's usually like a 4 or 5 window of time. So again, this type of study is not for everybody. If someone has seizures once a month, then they may not be, that epilepsy may not be a good epilepsy candidate for this type of study. But if the seizures are happening, or we can reduce medications in a way that they would be able to produce one within the confines of this tracer and the limitations of like planning for you have a seizure Tuesday morning, then like we need to like reduce medications in advance or do sleep deprivation or something so that the brain will produce a seizure in that window of time. So, this I think of all of the studies is like sometimes the most challenging because it's so unpredictable often when people will produce seizures, and we can try our best, and sometimes we're unsuccessful. But when it works, it can be really useful because we can find an area that has a difference in the blood supply and the demand of blood, which points to an area that's like really metabolically or more active in that seizure moment. And then at our center too, we'll usually have someone admitted to our epilepsy monitoring unit for like 4 days. We'll try for their ictal SPECT, their seizure 1 on one day. And then a couple days later, we'll actually do another injection at baseline. So an interictal SPECT. And then you can subtract the difference between the two. And that can just remove that other question about what if at baseline there's a difference in metabolic activity, even when they're not having a seizure. And so like when you look at the difference, you can really get more detailed, more granular about the hotspot. And then one of our colleagues in the Adult Epilepsy Center is also double certified in radiology and produces these beautiful images that can really like triangulate the hotspots in someone's seizure network. And then on top of that, we'll map these like ictal and interictal SPECTs on top of someone's brain MRI too to get that 2D map in their brain of where that seizure is coming from. I think this is the most like invasive of the non-invasive ones because it involves someone coming for like a week to be in our epilepsy monitoring unit, to having their seizure medications reduced to provoke their seizures, to get the timing and do the injection and the yada yada. So it's asking a lot out of people, and bearing that in mind, we want it to be successful. And so we'll be really frank with you about if we feel like this is a good idea or not for you or for your child in terms of how likely it is for it to be successful for you. And then we'll plan for it in advance. And so we'll know like this is the week of your ictal SPECT. We're going to plan to like reduce your medications on this day and increase the threshold or increase the likelihood that your brain will produce a seizure, and go over our contingency planning. If that happens, this is what we'll do to manage it. When do we restart medications, or how do we keep somebody safe throughout this process? Okay, and then the last type of imaging that I wanted to touch on briefly, I should have done this coupled with our EEG. Monica talked about this in the talk before mine, but you're pretty familiar with our regular EEG montage with all those electrodes taped on the scalp. At our center, we'll also add additional electrodes, which can then be processed after the fact to do this test called EEG source imaging. And so this also can be ictal if the EEG captures a seizure at the time. There's no tracer, there's no IV, there's no, none of all that stuff with like the ictal SPECT injection. But basically, when we're able to add more like dense electrodes in what we suspect to be the hotspot area, then we can apply computer algorithms to help us pinpoint to where the seizures are starting. And so this is called ESI, electrical source imaging. And so when you're coming to our epilepsy monitoring unit, we'll often place our regular montage and then come back and add a few more depending on what we're noticing in order to get this information later. And then the images that can be produced are also mapped onto someone's own brain MRI, like we see in this picture, in this example, to really pinpoint where we think the beginning of the seizure is. I also want to mention all of these have limitations. It's certainly possible that this is picking up where the seizure is spreading to, for example. So it's all really interpreted in the context of that person, what their symptoms are, and those conversations we have really openly about the benefit of these studies and also limitations in the context of planning for someone's surgery. Okay, and then to touch a couple words about neuropsychological testing, like we had talked about briefly. This is this huge laundry list on my clipboard here of the types of information that are obtained through neuropsychological testing. This is also asking a lot of our kids. They sit down with a neuropsychologist for like 3 hours, maybe a couple sessions, to do memory puzzles. We're looking at their attention, processing speed, problem solving, visuospatial memory, all these different types of things that there's no imaging to find. And so there's no other like test to find strengths or relative weaknesses in these areas, and it's really through neuropsychological testing that we can get a better handle of working memory and motor skills and visual processing, et cetera, et cetera. And again, this is not the end all be all. There's no like passing this or failing this, but it's more like adding more information to the overall functioning of the brain. And if, for example, if we suspect seizures are coming from like the left temporal lobe, we would expect to see relative strengths in parts that should be from the right temporal lobe and relative deficits in the seizure area on the left temporal lobe. And so we'd want that to match up. If we see neuropsych information that's different than what we expected, that's really useful to know. And that would help us to know for that person, is surgery worth it? Because we got this surprising answer, and is this going to raise the chance of a harm to that person if we operate or something like that? So, it's really viewed at our center as another piece to the puzzle that can help us to understand the other functions other than producing seizures or not that area of the brain should be doing. Okay, so then all that's done. We've done all of our testing. You guys have been heroes of enduring all the stuff that we do to people. Then we sit down in a conference room at UCSF. It's every other week. And it's this huge team of adult epileptologists, the other members of my team, which are pediatric epileptologists, our neurosurgeons, neuropsychologists, neuroradiologists, nurses, and each person's case, all this data are presented one at a time, and we kind of walk the entire group through the history of that person's seizures, the other neurologic or psychiatric symptoms that they may be experiencing, other relevant social information about how this impacts their quality of life and what they wish to be doing, their medication history, all of their imaging, their EEG, all these data are presented to the team, and then the team discusses it, and we talk about, well, did you think about this angle, or what about that perspective, and kind of the person whose patient it is may have some idea of what they wish for that person, and it's sort of like vetted and kind of put through this litmus test amongst the rest of the group about helping us think through our own biases, or what did we overlook, or what's another aspect that could be relevant for that person's case. So after that multidisciplinary epilepsy surgery conference, it's really one of my favorite parts of working at a place like UCSF, because we all benefit from this like collective wisdom and help us think through things that we didn't think about, or ways to explore surgical options for our folks that we're taking care of. Then we come back to the person and meet with you and kind of share the consensus opinion, and then go from there. Sometimes after that consensus opinion, it's meeting with a surgeon to get more information. At no point are you deciding or committing your loved one to going down surgery. Like, that hasn't happened yet. It's really collecting information. And so we would want to offer this to every person for whom they've failed 2 medications, or really our medications have failed you at least 2 medications, to like offer this as another treatment approach. And so after that, then you meet with the surgeon and talk in more detail about what they would want for you or for your child, and what they wish for, what they're worried about, what they think they can handle, what's their contingency planning for you to get that full information. And even at that point, up until the day of surgery, it's still your choice to go forward with it or not. But I view this entire all this so far as just your data collection, to really keep all of your options open. And again, sometimes the day after surgery can be like the first day of the rest of your life, which can be really huge for people or your loved ones struggling with having disabling seizures. So that brings us to this. What I would take away also, if there's one thing, is that all these treatment options should really be as broad as possible. It does not do us any service to say, like, right out the gate, this is happening, so you're not a candidate at all. Like, I would want to challenge that kind of old school way of thinking, especially as we have new emerging treatments on the horizon. So sometimes after we get our, sorry? Oh no. Okay. All right, well, I'm gonna just like fast forward to the end. We have, just in the last maybe 1 minute, we talked about resection. There are non-resective surgical treatments that are available for people, including neuromodulation, which can be super powerful, and it's emerging for children. There are actually some clinical trials enrolling kids. It's also currently used off-label in kids younger than 12. But hopefully it's not a binary of like you're either a candidate or you're not. It's really an evolving field. And then my last 2 slides are a study that I was part of to look at a type of genetic epilepsy that affects children. And we published our information about how a few of those kids were cured with epilepsy surgery. And so, I think another of our biases, our old school thoughts have been if you have a genetic cause for your seizures, then that's it. We figured out the cause, and then you have to live like that. But that's not always the case. And so even in the face of a genetic etiology for your epilepsy, there may be surgical treatment options. It's not like there's one or the other. And so our center published a small paper of kids with PCDH19-related epilepsy, and then a bigger consortium, the Pediatric Epilepsy Research Consortium, which is like a multi-center across the country group of researchers, all these different types of genetic causes of epilepsy and their experience with using epilepsy surgery, be it resection, be it neuromodulation, the whole litany can still be offered in the setting of having a genetic chromosomal change, and people can do super well. So sorry to breeze through the last few, but I'd love to chat afterwards for more questions. Go to a comprehensive epilepsy center, find out more.